Okay, so we've seen how we can think of the mirror system as an automatic system. That if we see somebody reaching for an object, the mirror system can automatically activate some of our own motor programs to help us understand the intention of that other person. And we've seen that the mirror system may be involved in imitation. And we've learned that certain kinds of brain damage can produce what some call environmental dependency syndrome, where the patients will just automatically imitate gestures of others and automatically sort of interact with objects according to their affordances. So that all fits this picture that the mirror system is sort of an automatic system. And the reason we don't imitate others all the time is that we have other brain systems that can inhibit the imitation. But we want to think of the mirror system as being sort of triggered automatically. Now, if the mirror system is also involved in feeling other people's emotions, right, the feeling component of empathy, well, then it raises the question, are we automatically empathizing all the time? But clearly we're not always empathizing with others' feelings. So again, there must be some system that can interfere with the resulting empathizing, just as there would be brain systems that inhibit automatic imitation all the time. So let's take a look at some of the research on how empathy can be modulated. Okay, so to understand some of the studies on how empathy is modulated by other factors, we'll need to learn a little bit about how pain is processed in the brain. Here we see the left hemisphere, looking at it from the side. So we have the cortex here. Here's the temporal lobe down here, the occipital lobe, the parietal lobe, and the frontal lobe. And just at this region here, so this is the parietal lobe, at the most anterior part of the parietal lobe is the touch sensory cortex, sometimes called somatosensory cortex, so S1 and S2. And here we have a kind of a map of our body in our brain. So if we are touched at a certain position on our skin, a certain dedicated area on this strip of tissue will become activated. If we stimulate that same area with an electrode up here, then we will feel some sensation at that location on our skin. So this is sort of a map of our body surface right here in the brain. There are two other areas involved in pain perception, and that is an area called the anterior insula, and this is a bit of cortex that's kind of tucked underneath this division here between the temporal and the frontal here, so it's kind of hard to see, but we're just going to put it right there. And then if we look on the medial surface, the middle surface of the cortex, there's a region on both hemispheres called the anterior cingulate cortex. So this is a kind of a cutaway. If we were to turn this hemisphere around and look at the middle surface of the brain, we would see a region here called the anterior cingulate cortex. Now, interestingly, pain seems to have sort of be processed in two different ways. The somatosensory cortex, the touch cortex, seems to process the intensity of the pain and its location. Given that this is a map of the body surface, that sort of makes sense. So if you have a pain in your toe, the somatosensory cortex will be registering that location and its magnitude. On the other hand, these two areas, the anterior insula and the anterior cingulate cortex, seem to be more involved with sort of computing the suffering component of pain. So we can think of pain as having different sorts of qualities and characteristics. There is the intensity of the pain, there is the location of the pain, and then there is this other aspect that we're going to call the unpleasantness, the discomfort, the suffering component. And this distinction between the suffering and the location and intensity also shows up in terms of some of the drugs that are used to manage pain. So for example, this area here, the anterior cingulate cortex, has opioid receptors. Cells in this area respond to narcotics like morphine. So if you are in chronic pain, maybe a terminal cancer, for example, one of the treatments to manage the pain is to give narcotics. And the idea is that the morphine can reduce the suffering component of the pain. But interestingly, patients report that they still might sort of feel the pain, but it doesn't bother them as much. So the drugs are knocking out the kind of unpleasant part of the pain without necessarily affecting a perception of where the pain is or some aspect of its intensity as well. So, just to recap then, if your foot is injured or your hand gets hit by a hammer or something, your brain will be registering a location for the pain and an intensity for the pain, and also sort of generating that kind of discomfort associated with the pain. So these three major areas are involved in pain. And when we ourselves are in pain, these three areas are activated. But now, to introduce the research on empathy, these same areas also become active when we observe somebody else in pain, right? And that is thought to be, again, revealing the activity of this sort of mirror system, that when we can see somebody else either injure themselves or see a facial expression of pain, and it will activate some of our own systems that would be activated if we ourselves were in pain. So in some of these empathy studies, what they're going to do is have the subjects observing pain being given to somebody else, and then measuring the level of activity in the pain regions, these same regions that would be active if the person were in pain.